My name is Jack Crow. I am an aortic dissection survivor, and I am an aortic athlete.
Hi, my name is Greer Schneider, and I'm 8 months post open heart surgery for an aortic aneurysm repair, and I am an aortic athlete.
Greer, it's so nice to see you. Thank you for joining me for the first time ever doing an interview for aortic athletes. Why don't you tell us just a little bit about yourself? What makes you an aortic athlete?
Sure. Hi, Jack. It is great to be here. Sports have been important to me my entire life. I played D1 tennis in college and kept active ever since. It was part of my identity. So fast forward to 2024, I finally retired and was looking forward to a life of lots of activity and lots of travel, but I got this terrible cough and my GP ordered a CT, and my lungs were fine, but they found two aortic aneurysms, one at the root and one in the ascending aorta. So I was in watch and wait for about a year and a half, and then last September, I had the elective repair at the Cleveland Clinic with Dr. Roselli, and I'm doing great.
Well, we're so happy to have you here. We're going to interview Dr. Singh in a minute. Just really quickly, how did your recovery from surgery go? Because it's less than a year now. You're just 9 months out, right?
Yep, 8 months out, and I'd say the recovery went great. I was climbing stairs before I left the hospital, and the next day I walked a mile, but I really attribute all of that to sort of training for surgery. I treated it as if it was my job, just to move every day. And then I got a great tip from another aortic athlete, Amber Williams, who said, make sure your core is strong. So I really just focused on functional activities like sitting on the floor and standing up without using my hands. And everything's great. 6 months post-surgery, I went to Belize and kayaked and, hiked and snorkeled too.
Wow, and I think I even saw a picture of you rock climbing, so that's pretty amazing. Well, it's a tribute to training for open heart surgery as appropriate for aortic folks. And we're going to have an interview today with Dr. Tamanna Singh from the Cleveland Clinic. But before we get to her, I want us to remember that today's conversation is for educational purposes only. We're not giving medical advice, and that's because each of us with aortic disease is different. Some of us have genetic or familial things. I have a familial thing. Some people have stable aortic aneurysms. Some people's are not stable. So you need to go and talk to your cardiologist about what's appropriate for you. And I think we want you to click like, join Aortic Hope for peer-to-peer support, join Aortic Athletes on Facebook for peer-to-peer support, particularly relating to exercise. And Greer, why don't you tell us a little bit about Dr. Singh?
Yes, we are so lucky to have Dr. Singh with us today. She is a leading voice on heart health for active people. She's the director at Cleveland Clinic Sports Cardiology Center and co-director of Cleveland's Women's Integrated Sports Exercise and Research Center, known as WISER, which is easier to say, which launched earlier this year. And I'm so excited because it's one of the first of its kind program that brings together medical care, mental health, nutrition, performance training, all under one roof, and designed specifically for female athletes. Her clinical focus has been helping competitive and recreational activities getting back to what they love safely. She's very much an athlete herself. She's a marathoner, a cyclist, a contributor to Runner's World, and a longtime medical volunteer at Boston Marathon. In fact, she is the cardiologist that helped our friend and fellow aortic athlete, Brad Way, return to the Boston Marathon just 5 months after his aortic repair surgery. So thank you so much for joining us, Dr. Singh.
Thank you so much for having me. It's a pleasure.
And Dr. Singh, you have some opening words for us. So we'll kind of turn it over to you, and we're all ears.
Wonderful. Well, a little bit about myself, like you alluded to. So I run, I try to stay active, and I think a lot of that helps me take care of my athletes and understand their perspectives, which I think is really important when you're a practicing sports cardiologist. One of the things we talk a lot about with respect to my athletes with aortic disease is how do we get through surgery and how do we get back to sport? And as you alluded to, Greer, I see a lot of women athletes, a number of which do have aortic disease, and there are some special considerations for women. So with that, I do have some slides here ready to go for you guys. Let me just share my screen. Okay, I just want to confirm everybody can see my screen.
Yep.
Wonderful. So we'll talk about always an athlete, aortic disease, and return to sport. So some of the objectives I just wanted to get across today was talking a little bit about aortic dilatation athletes, which I know with wonderful co-hosts as yourselves, you and your audience have discussed this to length, I am sure. We'll touch a little bit on surgical planning and then certainly post-operative recommendations, returning to sport, shared decision-making, and integrated care. So one of the things I always talk to my athlete patients about is how does the aorta actually respond to sport? Because I think that helps individuals understand which specific sport modalities or styles of training may be the most helpful to really mitigate any progressive disease or at least slow it down so we can delay surgery for as long as possible. And so the aorta dilates in response to high exercise volume. We see this both in endurance sport as well as strength. And with endurance, the increases in stroke volume, so the amount of blood that's actually pumped out of the heart per heartbeat, as well as the cardiac output, which is really a product of stroke volume and your heart rate, those both increase the stress on the aortic wall and could lead to some progressive dilatation. It really depends upon the actual volume and exposure to exercise over time. When it comes to strength, we have robust data to show that with particular types of weightlifting, certainly the 1 to 3 rep max lifts or lifting to failure, holding your breath or grimacing, we see these very high spikes in systemic blood pressure, which can lead to increases in the intra-aortic pressure upwards of 4-fold, and that can also lead to some progressive dilatation. There was a wonderful meta-analysis of about 5,500 elite athletes that did show that in that particular cohort of endurance athletes, there was about a 3 millimeter increase in aortic root dimensions versus those who are non-athletes. So there is some sport-related enlargement that we're seeing. That being said, there are some parameters that we can at least kind of utilize when we're assessing athletes with enlarged aortas. We typically measure right at the root of the aorta or the sinuses of the valsalva when we're thinking about aortic root or ascending aorta disease. Though you guys know, similar to me, that we have disease of the descending aorta as well, which could happen. We look at age, sex, body size, and for our biological males, upwards of 40 millimeters is what we would characterize as enlargement. And for females, 34 to 36 millimeters. We expect smaller aortas in females, and that will carry through in recommendations and timing for surgical repair or replacement. One of the things to note is we have an abundance of data in the NFL and the NBA and our endurance athletes where, we essentially have created a bit of a normative range where upwards of 40 millimeters to maybe 42, 43 millimeters seems to fall in line with what is normal for those particular athletes. So I definitely want to just get across that 40 and 34 to 36 for males and females respectively is not, end all be all. We really have to take that into account with, what that athlete does and how they look. Aortic dilatation is rarer in younger individuals and oftentimes more associated with hereditary causes or abnormal aortic valves like bicuspid or two leaflet valves. More common in masters athletes. There was a study of 422 endurance athletes ranging from ages 50 to 75. 21% of competitive rowers and runners actually had an aortic dilatation, of which the majority were men, 31% versus 6% women. So when we're thinking about aortic disease, it's really important to define the cause. We know that there's aortopathy associated with the bicuspid aortic valve. And interestingly enough, there's a very low risk of dissection with that particular cohort. Individuals with hereditary thoracic aortic disease are at higher risk at smaller aortic diameters. And some of these diseases include Loeys-Dietz, Marfan syndrome, Turner syndrome, and more. And so that's a particular cohort where we really want to make sure we're doing genetic testing, diagnostic surveillance early and often. And even if individuals may have the clinical features of these syndromes, but are negative for the actual genes, it's really important to remember that there may be some nature of those individuals having gene elusive hereditary thoracic aortic disease and to treat them similar to those who have positive genotypes. There's also familial thoracic aneurysms and dissections, and then certainly idiopathic unexplained, which accounts for about 1 to 2% of competitive athletes. So with aortopathy in athletes, I already kind of discussed the dimensions that we look at when we're thinking about biological males and females and actually qualifying them with an aortopathy. Again, rare in young athletes. And when we talk about distinguishing vocabulary, so what is dilatation and what is an aneurysm? Most of us in the sports cardiology world will characterize aortas, particularly our ascending aortas or thoracic aortopathy of we'll qualify them as aneurysms if they're 45 millimeters or larger. In terms of the risk of disease progression and aortic dissection, as well as sudden cardiac death, they're very undefined in competitive sport. And oftentimes, we don't see sudden cardiac arrest and death with exertion. In fact, sudden cardiac death due to aortic dissection is much less than the estimated prevalence of athletes with actual aortopathy. One of the things I oftentimes hear in my clinic is that people coming in for second, third, fourth opinions have been told you should only lift 10 pounds or you should minimize your weightlifting to less than 50% of your body weight, but that's very inaccurate, very inappropriate, and not based on any clinical evidence. And we can touch on that a little bit later when I'm talking about sport recommendations. Genetic testing is very helpful in establishing a diagnosis, but like I mentioned, we don't know all the genes that cause hereditary thoracic aortic disease. And so there's certainly gene elusive disease out there. But that can help with risk stratification for sudden cardiac arrest and death. And then it's really important to balance risk. We use shared decision making a lot when it comes to aortic disease, including other pathologies that athletes have. Longitudinal surveillance is cornerstone of what we do, and genetic testing as well is critical in athlete management. I always get questions about medications and whether or not there's a role in slowing aortic progression or progression of aortic disease. Beta blockers, very commonly asked about. And so I wanted to touch a little bit on the benefits and the impact that beta blockers can have on athletes. So we know that they help to reduce the stress on the aortic wall by reducing blood pressure and heart rate. And in that regard, we can see some slowing of progression in aortic enlargement. It doesn't mean that your aorta will never grow, but it may help to buy some time before surgical repair and replacement. In terms of how it impacts performance, it really depends on the athlete. I have some who can tolerate high doses of beta blockers and have no impact on performance, and I have others who cannot tolerate even a sprinkle of a beta blocker. They feel like their exercise tolerance is very much blunted. They're hitting a wall when they're trying to push into threshold or higher zones. And the reason for that is when you can't attain a higher heart rate to account for the intensity you're trying to achieve, it really does reduce our oxygen consumption that's attainable. Not necessarily our VO2 max, our physiological max, but certainly our peak in that particular scenario. And then for people who are competing on an elite level, beta blocker use is prohibited by our anti-doping agency. And so those are things to really take into account when we're counseling on medication use. We take a very individualized approach. And when I counsel individuals who are on beta blockers, we talk a lot about training by effort rather than heart rate zones. And that can be a whole conversation in itself. Another medication group that has been shown to slow progression of aortic enlargement are statins. So statins are medications that are very common, particularly correlated to lipid lowering therapy. So they're very good at reducing bad cholesterol or LDL in the blood. What we know about statins and aortic disease is that high doses can reduce the rate of aortic dilatation by about 0.8 to 1 millimeter annually, which is pretty good. Again, it doesn't prevent, but it does delay progression of disease. It can also reduce the risk of aortic rupture by actually strengthening the integrity of the aortic wall. And we have seen that preoperative statin use is also associated with lower mortality and complication rates. When it comes to acute aortic syndromes, these are things like aortic dissection, so when the wall of the aorta splits apart, or rupture, which is catastrophic and an emergent episode. Otherwise, people can die. It's an extremely rare cause of sudden cardiac death in competitive athletes. And like I alluded to, most of these acute aortic syndromes do not occur during exertion, which is a common misnomer. Most frequently, acute aortic syndromes occur most frequently in athletes who have heritable thoracic aortic disease. We have a new set of guidelines. Our initial guidelines for competitive athletes from the sports cardiologists of our network were published back in 2015, and last year we released a wonderful new update. So I encourage our audience to take a look at this to get a general consensus of what our recommendations are. But I wanted to just highlight that, thoracic aneurysms and aortic dilatation is not an end-all be-all when it comes to competitive sports participation. It really depends upon what the cause is and what the sport is, and certainly the measurement and the ongoing commitment to surveillance imaging. And so we use shared decision making when we talk about participating in sport when someone's been diagnosed with aortic enlargement or an aneurysm. And that's, where here we mentioned that competitive endurance sports can be considered for masters endurance athletes who have unexplained thoracic aortic aneurysms between 45 to 49 millimeters. And we certainly can counsel on resuming competitive sports participation in that particular cohort after they heal. I wanted to just focus a little bit on aortopathy or aortic disease in females. So this is specific to all females. There's really a paucity of data in female athletes in general. Only about 6 to 9% of publications actually look at biological female athletes. And so you can imagine that the number of studies looking at female athletes with aortic disease is few and far between. But I wanted to highlight this wonderful paper from Circulation Research published last year, which talks about some of the findings and some of the things we do know about aortic disease in females. So females, unfortunately, are at 3 times greater risk of aortic rupture or dissection of their thoracic aneurysms, and they are 40% more likely to die from aneurysms. Interestingly enough as well, we oftentimes use population data to provide criteria for surgical repair and replacement of the aorta. It's important to note that 50 millimeter ascending aortic aneurysm in a female is actually pretty equivalent to a 60 millimeter aneurysm in a male. And so even looking at our guidelines for incidental aortic disease, 55 millimeters is typically our cutoff for when we recommend what is a class 1 indication for surgical repair or replacement. And if you're looking at our biological females, they're already at probably exponentially higher risk at that dimension, and they may need to be treated sooner. With respect to just the epidemiology, so 32% of individuals with thoracic aortic disease are female. They tend to present at older ages, which is related to the decline in estrogen during perimenopause and certainly after. That estrogen is really valuable for vasoprotectivity and preventing arterial damage. And once we lose that estrogen after menopause, the vascular elasticity, the strength of your aorta actually declines. We can also see increases in arterial stiffness, and that's also when we start to see cardiovascular risk increase as well. And so I would highlight here, if you're a master's athlete in the perimenopause, menopause state, if you know of any family histories of aortic disease, certainly talk to your provider or cardiologist about it. But also if you're starting to notice other things like, your blood pressure is a little less controlled, you have other kind of cardiovascular risk factors simmering, it may not be a bad idea to talk to your doctor about whether there would be any reason to warrant some, initial preliminary imaging of your aorta. With respect to presentation, so symptoms tend to be more atypical in females, and we see that kind of across the board when it comes to coronary disease, let alone aortic disease. And just in general, females tend to seek medical attention for things that are cardiovascular and non-cardiovascular much later than males. And there's many reasons for why that likely happens. Because females present atypically and differently, and because not a lot of people are thinking about how females with smaller aortas may actually be at higher risk, may not be aware of that, they also experience greater delays in diagnosis and treatment. And so it's really important, I think, for us providers certainly to have our antenna up when we're seeing females with some family history of aortic disease or some cardiovascular risk factors that would up our suspicion for assessing for aortopathy. When it comes to treatment and survival, we really want to address surgery in females at smaller dimensions. Unfortunately, fewer females undergo surgery, and oftentimes they undergo simpler repairs, which may not be appropriate. And as a result, their mortality is much higher than males. So there's a lot that, I think can be spoken upon when it comes to just healthcare in general for females, which is why we developed a specific center to help our active women and those seeking to engage in movement. But I think this paper really highlights the disparities, the gender disparities when it comes to aortic disease. One of the things to certainly consider if you're pregnant or if you are seeking to get pregnant is really getting genetic counseling if you have known hereditary thoracic aortic disease, undergoing ongoing surveillance with echo imaging or CT, sometimes MRI as well, and just being aware of the specific dimensions that would apply based upon the hereditary disease you may have. During pregnancy, we do see changes within the physiological parameters of blood flow. We see increases in our stroke volume and cardiac output to account for that fetus. And there's increases in hemodynamic demand and, like I alluded to, blood volume. Sometimes our pregnant women also have blood pressure issues. And so if necessary, we certainly counsel on obtaining an echocardiogram as preliminary diagnostic imaging and advanced imaging if needed. For people who do have hereditary thoracic aortic disease, when it comes to delivery, that's going to be a shared decision with your cardiologist and your obstetrician. And often, I don't want to say oftentimes, but sometimes we do need to deliver by C-section, depending upon how the aorta looks. If there's a chronic dissection, depending upon the dimensions. Typically, fetuses can be delivered safely via vaginal birth if the aortic diameter is less than 40 millimeters. And then certainly, pregnancy and delivery is not the end-all be-all. There is such a thing as that final trimester after pregnancy. And, we can see dissection in the first 12 weeks postpartum. So you want to continue with imaging surveillance and continuing to mitigate your risk factors as well. When it comes to surgical planning in general, timing really depends upon the cause of the aortic disease. Is it hereditary or is it not? And I put a couple of kind of baseline guideline recommended parameters. And these are going to be things that you talk to your cardiologist about when you're looking at your imaging and the rate of growth. So it's not the end all be all, but certainly a guide. We always talk about the modality. Is this going to be open aortic surgery, meaning open, breaking your breastbone or going through the abdomen, or will this be an endovascular repair with a stent going through the groin and a catheter? And then is this going to be an aortic repair or is it going to be a replacement with a graft? And so these are all decisions that surgeons help our patients make. After surgery, it can be, I think, for some athletes, there's certainly, and probably for every athlete, there's certainly sometimes a question of self. You've gone through kind of this angst and lead up to a big day where that aorta has now been quote unquote fixed. You're in a bed, you've just gotten the breathing tube taken out. We're trying to get you to walk with our physical therapist. You're sent home with instructions of keeping, activity to a minimum, letting your sternum heal. It can really be a whirlwind. Some people really have no issues with that psychological and physical transition. And some athletes really do struggle. And so I do always take pause and want to recognize that to whatever degree and whatever it means to you, trauma is trauma. And this is a stressful event, not just psychologically, but for the body and your nervous system. So we really do a lot of counseling before surgery and certainly immediately after it. And in that first 6 to 8 week follow-up visit of how is the mind doing? How is the body feeling? Respecting the surgery, respecting the stress that just happened on your body, and understanding that the tortoise really beats the hare when it comes to rehabilitating after surgery. So cardiac rehab is an organized program. It's typically 36 sessions about 3 times a week that we have athlete patients start 6 to 8 weeks after surgery. There's a lot of standardization that goes into what that exercise prescription is going to be on a daily basis. But this is where, depending upon the center that you go to and the communication that your cardiologist has provided to the cardiac rehab center, we have the ability to individualize the approach. So we don't have, someone who is a very fast marathoner walking at 2 miles per hour, feeling like they're not getting anything out of their rehab session. So we want to tailor this to certainly addressing the deconditioning that has happened postoperatively, but acknowledging that that athlete may bounce back a bit faster than someone who was sedentary before. And one thing I will note is when it comes to exercising before surgery, we really encourage continued aerobic activity, provided individuals are not symptomatic or having any other issues, just to, again, build someone up to the best capacity. So when they go through kind of detraining, deconditioning, loss of muscle mass through surgery and early parts of cardiac rehab, they have the capacity to maybe bounce back a little sooner than other individuals. A lot of my athletes go to cardiac rehab and they say, this is a joke, this is too easy. That's where we start to focus on, well, is there an ability to individualize the actual approach at the center? And if so, great. And if not, let's start incorporating some activity together outside of cardiac rehab. And I certainly encourage that type of additional exercise. Again, counseling, hey, let's take it slow and steady. Treat it as if, you broke an ankle. You're not going to start jumping on that ankle immediately, right? We're going to kind of slowly get into it, build up the strength around the ankle. Same with the aorta. And then after that, and certainly, leading up to surgery, we will have conversations about what return to sport may look like. But as we're getting through cardiac rehab and assessing our athletes, we're then able to get a bit more specific about what is our return to play progression going to be. When we do return to sport, again, it's going to depend upon what the actual cause of the aortic disease was. In non-hereditary aortic disease, there was a great case series of endurance athletes who had bicuspid aortic valves, had aortic resection and no complications in 8 years of follow-up. And these were athletes who were doing, triathlons and marathons and the like. When it comes to hereditary thoracic aortic disease, we know that there is an increased risk even after repair or replacement of distal aortic aneurysm and type B aortic dissection, the latter being a dissection beyond the arch in the descending aorta. So counseling will be a bit different for both groups. With respect to our guidelines from 2025, so the one thing I wanted to highlight here is with respect to competitive sports participation and those who've undergone aneurysm resection for unexplained aortic dilatation, we can continue to consider and support competitive sports participation. Again, it will be different for individuals who've had hereditary thoracic aortic disease and had aneurysm repair. And in that particular group, we still use shared decision making, but oftentimes say, it is likely going to be safer to maybe avoid very elite competitive sport, but it's always a conversation. So like I'm kind of getting to, return to play is an individualized approach, and it really takes a team. So, when we have team athletes who have stakeholders, certainly their family, their treating physician, any subspecialists outside of their cardiologist, their trainers, the owners of teams, et cetera. It really does take a team, but at the end of the day, we're advocating for the athlete, making sure that they understand the risks and the benefits of moving forward, making sure that they feel like they have good data to support their decision, and reminding them that at the end of the day, it's okay if they don't want to return to competitive sport. And even if they can, sometimes athletes decide, I want to play it safe, or I don't I don't see myself as someone who needs to be in the elite field. Everybody really is different when it comes to disease management and moving forward with their relationship with sport. We do a lot of goal setting in our sports cardiology center as well as Wiser. We work with our sports social worker and our athlete support team, sports psychology, and certainly talk to our stakeholders as needed. We focus on psychological readiness. We do a lot of psychosocial evaluations. We focus on mental confidence and reassurance in an athlete's body. You can imagine, you both are probably well aware, it takes time to trust that your body can do what you need it to do, to trust that your chest is fully healed, that your, breastbone's not going to break apart all of a sudden. And so we really have to work on building that mental resilience and that confidence so you can really get the most out of performance on race day and certainly in training. And then performance checks are certainly helpful. I do use a lot of time to make sure that we're not missing anything if athletes are symptomatic. We tailor it to the actual sport modality that our athletes do. And I think it, again, helps with that confidence and confidence building and reassurance. So our approach is we have an athlete support team that kind of helps with that ecosystem of the athlete. This is integrated in both our sports cardiology center at the Cleveland Clinic as well as Wiser. And speaking of Wiser, so it's been about 3 months since we opened up our doors. It's the Women's Integrated Sports Exercise and Research Center. And this is where we have a really integrated care model that's athlete-centered. And so we focus a lot on integrated care and communication. All of us providers are talking to each other on a weekly basis about the patients we've seen and the patients coming up. We have our athlete support team led by our wonderful licensed sports social worker, Barb Anthony, and she's really kind of the person who mediates and supports the athlete and the care team. I kind of think about us as an Oreo cookie with medical providers as one of the cookies, our athlete patients as the other, and our athlete support team is really that creamy middle that keeps a cohesive care across the board. We have 4 care paths. We have kind of an acute injury transitional path, a longitudinal performance. We do provide event-based care. And then, of course, we have elite care for our partnerships within the enterprise. And if you have any interest in learning more about us, you can certainly check out our care page or send us an email if you'd like to be seen. My fellow co-founders are Dr. Marie Schaefer, who's board certified in sports medicine and family medicine, and Barb Anthony as well, who's our clinical lead for the athlete support team. The 3 of us, we kind of came together and really noticed and had been recognizing for years just the lack of support for active women, and we really wanted to do something about it. And they're 2 wonderful women that I encourage everybody to learn more about. We are continuing to expand. We have experts in sports medicine, sports psychiatry, certainly sports cardiology, obstetrics, gynecology, adolescent health as well, sports dermatology, sleep medicine, and sports dietitian, and finally physical therapy. So a lot of people in our group, again, creating a nice cohesive structure to support the ecosystem of the athlete, not just one organ here and one organ there. So just to wrap up, some of our take-home points is aortic disease is rare in young athletes, certainly more common in masters, but it can happen. And defining the etiology is key. The big thing to remember is that return to sport and a meaningful relationship to sport, whatever that means to you, is possible. And we really do take and honor an individualized approach when it comes to rehabilitation, building back training, and getting back to the start line. Aortic disease is very different in biological females, but I think at Wiser, we certainly have the capacity to get some research going, build a database, and really get more nuanced about our approach to our female athletes with aortic disease. So thank you so much.
Dr. Singh, that was terrific, comprehensive, and we have a lot of questions for you. And probably the first one is, so aortic athletes, we have like 2,300 people from around the world in all various forms of aortic disease. And a lot of your presentation was about how individualized the approach is. But here's one thing that's kind of common that we see when people first join their group. They join our group and they say, I've been diagnosed with this, maybe a dissection, maybe a dilation, maybe an aneurysm at 4 or 5 or greater. Maybe they're heading into surgery and they think, my life is over. That's the commonality. And, you know, with peer-to-peer support, and it's kind of like our motto is don't quit, adapt, and we follow the science. How do you, if you take those two, let's say two groups, one is post-dissection and one is post-diagnosis, going to be in watch and wait for a while. How do you approach them in your first conference with the patient?
Well, I usually try to get a sense of who they've spoken to, where they're getting their information. Because when you don't do a lot of management of athletes with aortic disease, you know, a lot of provider personal biases can get in the way. So I can easily imagine a provider who doesn't have the experience saying, whoa, you have a big aorta. I don't think you can do anything. Maybe because they personally have a fear that this individual is going to be at higher risk, and potentially they just don't know the data, or they don't have the resources to find people like me who do, you know, take care of a lot of these individuals and have more comfort and confidence in our recommendations. If we're looking at those two populations, people who've had dissections or who have chronic dissections versus those who've just been diagnosed, I would definitely be, you know, treat both very differently, just because chronic dissections and the hereditary kind of association with dissections oftentimes will make me be a bit more conservative in our conversations about exercise, the types of exercise, versus people who may have an unexplained cause for the aortic disease. They just have dilatation, no other risk factors. Maybe they have high blood pressure that we can manage, but really impulse control and ongoing surveillance, and maybe a more liberal approach to activity with some discussion about how strength training is going to play a role would be the conversation I had with that latter group. So this is again like kind of that approach where we have to assess what kind of disease does the athlete have. The disease will help me understand what their risk of having progressive dissection or rupture will be. What kind of sport do they want to, or sports do they want to play? What are their goals in sport? Is this someone who's gotten a diagnosis and is like, I honestly don't even want to, you know, do X, Y, and Z? I would probably remind them that cardiovascular disease is the #1 killer, where movement and exercise is very helpful for cardiovascular risk reduction. But there's so many different factors, and it really is an ongoing dialogue. It's not necessarily something we get done in one session, right? These are open conversations with moving parts, and I think athlete patients should feel empowered, and you know, they have the agency to kind of make the decisions and take the time that they need, provided that we're making sure that we're monitoring that aorta as closely as possible.
And the science has advanced, it seems, so much, and the data has advanced quite a bit in the last 5 to 10 years. You mentioned the study of endurance athletes, bicuspid repair with people doing endurance events. And you mentioned our friend Dr. Tim Churchill with the rowers and the marathon runners getting echoes and showing enlarged dilations, not that unusual and maybe benign. I don't know. What data would you like to see? In other words, what's missing? Because part of, I think, aortic athletes, our role is really to provide the participants when you all are ready to do studies.
Yeah.
Where should the science be going for athletes?
Yeah, I think we have more growing data on what potentially are normative values for athletes. And I know, you know, Tim is working hard on kind of seeing what that looks like across sport modality, certainly in the endurance world. I think the place where we can continue to grow data is really in the post-operative surveillance. You know, we are basically making decisions about return to sport, aortic surveillance, and risk of any progressive aortic disease based certainly upon the diagnosis, but you know, kind of what we've seen in practice. There's no large registry that I'm aware of where we followed individuals post-aortic repair replacement for 10, 20 years, monitored their exercise capacity, looked at the strength training that they've engaged in, or the aerobic volume or exposure to exercise that's gone on in that period. We don't really have that kind of longitudinal prospective data. I'd be interested to see, you know, do we see any variability in aortic dimensions? You know, are these repairs and replacements holding as long as we see that they're holding, or we think that they will hold? I think those things might also offer athletes with aortic disease who are nervous about surgical repair and replacement and what that means on their future relationship with sport. I think it'll offer them hopefully some reassurance and confidence if we really don't see any elevation in risk of progressive aortic disease or sudden cardiac arrest or death.
Greer?
Yeah, as a follow-up to that question, kind of leads right into what one of our aortic athlete, Frank, asked, and he sent it ahead of time, saying, and he writes, given that resistance training is one of the most commonly practiced forms of exercise worldwide, can people return to weightlifting, CrossFit, calisthenics, and other high-intensity strength sports after a surgical repair of an ascending aortic aneurysm with no dissection? So it kind of leads into saying, well, what do you tell without all that data that you're hoping that you can get someday?
Yeah, this is where we really rely on expert opinion within our network of sports cardiologists and people who take care of athletes with aortic disease. Again, it's going to depend. It'll depend upon what caused that aortopathy to begin with. It was hereditary. I would really counsel about, the risks of developing aortic aneurysms elsewhere, particularly with, 1 to 3 rep max lifts or Olympic powerlifting or grimacing, valsalvating, holding your breath, bearing down, all those things that really increase that intra-aortic pressure upwards of 4-fold. If it's an individual who had like an unexplained incidental finding of aortic enlargement or aortic aneurysm and has that repaired, we talk a little bit about the return to, let's say, for example, CrossFit. What are your goals with CrossFit? What are your lifting goals? There is a role for strength training in people who have aortic disease now and those who have surgical repair replacement, but it's more modification. I would still, and this is my personal bias, I would still counsel that we don't really need those 1 rep max lifts or 1 to 3 rep max lifts to maintain muscle mass, to build muscle, for hypertrophy, for power. And I think my personal bias is because I don't know the data post-aortic repair replacement for Olympic powerlifting or powerlifting, Olympic lifting. To me, physiologically, it makes sense to do something along the lines of 5 to 8 reps a set or 8 to 10 reps a set, where you could do 2 or 3 reps more without holding your breath, breathing through that, keeping it more focused on strength endurance versus kind of maximal strength and maximal power. We get a lot of cardiovascular benefit from that style of resistance training. We see reductions in blood pressure, reductions in blood sugar control, or improvements in blood sugar control, improvements in blood cholesterol, improvements in body composition. I mean, for women, where we're really encouraging strength training and protein consumption, particularly as we age and go through perimenopause and menopause, with aortic disease, we still want to do those styles of strength training to help, keep our bodies healthy, mobile, powerful, help with our bones. So there is a role for strength training. And I think you can do that style, provided that you're okay and open to some potential modifications when it comes to things like CrossFit or something that's more aggressive in terms of strength. Interval training, I think, is predominantly going to be aerobic, right? So aerobic activity is fantastic. We don't see any escalation in the intra-aortic pressure to the degree that we see with strength training. So I'm very liberal with aerobic activity. You want to keep doing it, keep doing it.
Excellent. So you've mentioned aerobic activity, and you mentioned sort of cardio rehab. How do you help patients understand post-surgery how to get mobility back in their chest and not being afraid? Like, yes, it's healed, but I mean, I can tell you one shoulder isn't doing the same thing as the other shoulder after the surgery. Any advice on how people should sort of work on regaining mobility after surgery?
Yeah, so one, confidence. And I usually will tell individuals who are really nervous about their chest opening up all of a sudden, is that, we say you can drive after 6 to 8 weeks because we don't have that concern anymore that the airbag is going to disrupt that sternum. And if we're okay with an airbag, then that sternum is not going to open up. And so when it comes to mobility and strength, this is where I think a comprehensive physical therapy evaluation can be really helpful, because they will put you through the motions and they are, more well versed in how to give more nuanced, individualized recommendations depending upon any asymmetry in strength. Or if someone says, hey, like my chest is really hurting when I'm trying to do these particular movements, they can actually tell you, well, let's really increase your back and your core strength and focus on, your shoulders or XYZ. And so I really lean on my sports medicine PT colleagues to help do an evaluation and a thorough assessment, and then identify those asymmetries and create a plan.
I have enough gray hair to ask about masters athletes. So what's different about us? How do you approach us differently? How do you define a masters athlete?
Yeah, so generally speaking, masters athletes are really anybody above the ages of 35, though we have older masters above the age of 50. When we're talking about aortic disease specifically, oftentimes our younger individuals are going to likely have more hereditary aortic disease or bicuspid aortic valves with associated aortopathy, whereas our masters athletes who have, well, they might have two different things, right? If you've been an endurance athlete for decades and decades, that exposure to exercise, as Tim has demonstrated, may lead to some enlargement of aorta that is sport related and physiologic. But also masters athletes are not, immune to having general cardiovascular risk factors, right? Like elevated blood pressure, for instance. It's not uncommon for me to see athletes in their 50s come in with blood pressures 140s to 150s for their systolics and say, hey, my aorta seems to be measuring 4.4 or 4.3 centimeters, and I don't know why. So I think for masters athletes, there's a lot more counseling on how can we, improve general risk factors like blood pressure. I think we certainly see a number of individuals who have hereditary disease. But a lot of times I will say that people find me because they happen to get a chest x-ray that led to a CT, or happen to get a CT for, maybe a cough or pneumonia, and someone just was like, whoa, your aorta is 5 centimeters. Those are a bit, I think, more challenging conversations because you really don't know your aorta is big until someone tells you or it blows, right? So, not to jest about it, but it's like blood pressure and cholesterol. You don't know until someone tells you. You don't feel your aorta, right? So I find that those conversations can be a little harder just because, athletes have to now sort out how to deal with this new diagnosis that they may never have heard of that doesn't seem to make them feel anything. How do you reconcile that that's actually something to be concerned about? And that's where our athlete support team and integrating sports social work, sports psychology, and psychiatry can be really helpful.
And those 2025 guidelines seem to try to move away from the dimension being the sole factor, and it's more of a holistic approach. And that kind of also dovetails into the notion of joint decision making. So how has joint decision making changed your practice of sports cardiology? And how do you deal with crazy endurance athletes and crazy weightlifters?
So I think just in general, I had wonderful mentors who taught me about shared decision making really early on as a trainee. And so it's been something that I've always integrated in my practice. And I've never been one, nor do I agree with a paternalistic approach to medicine. My job is not to tell someone what they can or cannot do. I mean, it's your life. Like, you can do whatever you want, right? But my job is to be a responsible medical provider, someone you can trust and rely on to give you the evidence and the experience that I'm aware of, to share my anecdotal knowledge, to provide some guidance so you can make an educated decision. Sometimes some people will say, well, then I'm alone in my decision making. You're just giving me information. I have to digest it and then come up with an answer. And that's not the case. No, it's a conversation. I love to learn about what makes my athletes excited about movement, what they want their relationship with exercise and sport to be, because that just helps me be better at kind of providing them with guidance on what can we do, and what things maybe want to have another conversation about, what things might we want to modify. I like to call myself an optimistic individual, but also a realist. So I tend to practice and counsel from a place of hope, because I've been in this long enough to see things happen that I never would have expected in a positive way. And I think with shared decision making, when you have that empathy and that support and that advocacy, and that athlete really feels that you truly want the best for them, and that you also acknowledge and respect their agency and you're empowering them to really make the best decision for themselves, they'll hear you. They'll digest what you're saying, and they ultimately get to that same place on their own. But it takes two to tango. Sometimes it takes three to tango, and it takes time. Shared decision making doesn't necessarily happen in one visit. It's just ongoing counseling, seeing where your athlete is at, what can you help them with, give them the evidence, show them the data, sometimes I have patients who show me data that maybe I haven't seen. But it's an ongoing dialogue.
That's great. Can I change the path a little bit to bring in another question from an aortic athlete? Because I think if they take the time to write them in. But we had aortic athlete Passionate Hamster ask, is it safe to take hormone replacement therapy after aortic repair? And which types are more ideal? And if you touch base on that through the Women's Center.
That's an excellent question, one where we really don't have any data. And yes, we have wonderful obstetricians, gynecologists within Weiser who help us a lot with hormone replacement therapy, and the type that would be best for specific individuals. As I'm learning and as I'm finding, the mode of HRT is really going to be important just in terms of general risk for breast cancer. I think the data for topical is much better than oral. And then, whether you're doing estrogen and progesterone or whatnot, and what your, gynecological history is really important when it comes to picking HRT. I already mentioned that estrogen has some vasoprotectivity to it. And so I can imagine that HRT, similar to, maintaining normal lipids and helping slow down the changes in body composition or increases in visceral fat with perimenopause, I can imagine that HRT would likely help with your aortic resilience. We just don't have the data to show that.
Thank you. Can I take one more, Jack?
Yeah.
One thing that I know is really near and dear to your heart is that you've done a lot of research on plant-based diets. How does that impact aortic athletes? How should we think about diet and plant-based for those who are, focused on that?
Yeah, so there's more and more data, and I'll refer you guys to a wonderful series of nutritional controversies that were published in the Journal of American College of Cardiology starting, I think, in 2017 through the years. Some great visuals and just great information on all the data that we know about pro-inflammatory foods, and it helps to break down controversial foods like eggs, for instance, or seed oils, which is a hot topic these days. But what I find in not just kind of the aortic space, but certainly the cardiovascular space, is the less inflammatory we eat, oftentimes the better our bodies feel, and we also see great performance. That's not to say that people who are not entirely plant-based are not going to get the best performance that they want. Everybody really is different. Everybody responds to food differently. But what I'm finding is when we lean into colorful foods full of nutrients, you certainly can get all of the macronutrients you need from plants. I will say, especially for my female athletes and for my solely vegan athletes, oftentimes we need to look at iron studies, vitamin B12 levels, and make sure that, if those are not within our normal ranges, that we're supplementing, because those are things that can easily get low and impact performance, lead to fatigue, difficulty breathing, chest pain, just a whole conundrum of symptoms. And those are really low-hanging fruits that we can mediate with supplements. But there's just so much data, and I know, I never like to plug documentaries, but there's also a bunch of documentaries showing, I think Game Changers is one of them. I had my parents watch, but performance is so much about balancing inflammation, load, and recovery. And I really do believe that nutrition can either be really helpful in the inflammatory space or can be really harmful.
Thank you.
Well, Dr. Singh, aortic athlete named Michael Lopresti, who had bicuspid aneurysm repair he's in that group, no family history, anything like that. Just finished a 6-day ultra. He ran like 300 miles, and he's a vegan. Somehow he's figured it out. Well, as we close here, you mentioned the people who have the cardiologist who said don't lift more than 7 pounds, and we hear that more often than we should. And relatedly, it's also hard to find a sports cardiologist. I think many of us, the best we can hope for is a cardiologist who looks at us when we say, I'm post dissection 3 or 4 years. I've been jogging. I did a half marathon, and I think I want to jog a marathon. And they don't look at you like you're crazy. Which I had a nurse practitioner who said, "Why on earth would you want to do that?" And I've now done 2 marathons. I've retired from the sport. I got them done post dissection. But how do you at Weiser and at Cleveland Clinic at your sports clinic? Do you do remote conferences? Are you able to connect with people if they have access to insurance and stuff that will cover it?
Yeah, so we have several different programs in terms of having athletes actually be seen and evaluated. Certainly, you can come to Cleveland. We also do virtual visits. We also do second opinions. So for some individuals who may not be able to travel, they can send their data. I can take a look at it, and they can kind of list a series of questions that I can respond to. And from there, if we needed to do a phone call, we can actually even do that as a virtual second opinion. So there's different ways. I would say, when in doubt, shoot us an email. We're always happy to help you if you're not within the area and you're looking for a sports cardiologist. And we have some well-trained ones, certainly out east. In the Northeast, we have a couple out west. We have some down in the South. So I'm very open and always happy to help. Send us an email at sportscardiology@ccf.org or wiser@ccf.org. And if we're not able to help you here, we'll help you find the resources. In terms of education, I'm all about it. So I think, modes like this, as well as community places where I can speak, those are other ways for us to just do more expansive community outreach, which is always a joy for me.
Well, Dr. Singh, thank you for advocating for us. We're very grateful, and we're grateful also for you listening to us on joint decision making, and as appropriate, working within our limitations too, and being and realizing that this is a lifelong disease. I've heard Cleveland Clinic folks say for a long time, this is a lifelong disease, requires a lifelong plan. I don't know if that was Roselli or somebody said it somewhere along the line. And so we're very grateful to you, and we're grateful for all of our friends at Cleveland Clinic, and we're so pleased to have had you here as our guest.
Thank you so much for having me. It was really a pleasure. And you guys are doing incredible things. I think forums like this that provide really solid education and, highlight a lot of what we bring to the sport, and certainly highlight your experiences. I think that really helps all of our athletes build a lot more confidence, keeps them well informed, and certainly gives them a nice, safe space and community. So thank you so much for bringing that to all of our wonderful athletes.
Well, Greer, thank you. And to our audience, we'll see you next time. We have more interviews coming with world-renowned and terrific cardiologists for our aortic athletes. Good night.
Good night. Thanks, everyone.